Dr. Chrysopoulou, thank you so much for coming on to the podcast.
Yeah, pleasure to be here. Thanks for the invitation.
Before we start today's conversation, and it's all going to be about DIEP reconstruction or DIEP reconstruction, could you just tell us a little bit about yourself?
I was actually trained in the UK initially, left for the US in the late 90s. I'm part of a soon to be 9 surgeon team in San Antonio, Texas. Our practice is PRMA plastic surgery, and we focus on breast reconstruction, in particular using the patient's own tissue. So we do implants too, but our main focus is what's called autologous reconstruction, which is using the patient's own tissue. Ancillary procedures that are related to that, things like lymphedema, for example, surgical procedures to help with lymphedema. We do a lot of nerve work to restore feeling after mastectomies in conjunction with our reconstructions. So that's really our focus. It's tissue-based breast reconstruction.
Okay. And what kind of tissue-based reconstructions are available to patients? Because, reconstruction as a way to reconstruct a breast or create a new breast following a mastectomy, which is when we would normally recommend somebody to have a reconstruction, should they wish to have it, of course, because you don't necessarily have to have a reconstruction if you don't want to. What are the options if one were to go down the autologous route or using your own body tissue?
Yeah, so there are several options. It really depends on your body habitus, how much tissue you have, and how and where you carry it. So the most popular options, flap options. So these tissue reconstructions, they're called flaps. So a piece of tissue that's used for a breast, that's referred to as a flap. So you can get a flap from multiple different parts of the body. The lower belly, the lower abdomen is the most popular. It has been for many, many years. Starting off with the TRAM flap, which used the lower belly, skin, fat, and muscle. And that's now evolved to today's kind of gold standard, which is the DIEP or DIEP, depending on which side of the pond you're on. The benefit of that is absolutely massive because it preserves your muscles, your abdominal muscles, your six-pack. And that way your recovery is easier and the risk of complications, like a hernia or a bulge or a pooch, is much, much less. So we very much consider the DIEP flap the gold standard in tissue reconstruction. But some women don't have lower belly tissue to spare.
Right.
Whenever you remove tissue from one part of the body and transplant it or move it to another part, to the chest, that involves creating a scar at the site where the tissue came from. That's called the donor site. Some women don't want a permanent scar on their belly, on their lower abdomen. We try and make it as much like a cosmetic tummy tuck as possible, with the scar really low and really focusing more and more on the aesthetics of the abdomen. But some women, really like their bellies and they don't want to have a scar there. And
Yeah.
some women carry their weight differently on the thighs or on the back, on the buttocks. So those are the basic options in terms of location where the tissue can come from: belly, thighs, buttocks, back. Then there are some other, and the thighs, for example, they have multiple different thigh flap options. It can be inner thigh, it can be the outer saddlebag area, it can be the back of the thigh underneath, just below the buttock crease. And then there are other more kind of what we consider fringe options that aren't done very often. Things like the love handle area, you can that can be moved to the lumbar artery perforator flap, for example. So basically, wherever you have tissue, I mean, chances are, if you go to a center that specializes in microsurgical breast reconstruction, you're going to have you're going to have some options beyond just
Right.
an implant. And also,
Right.
I know we're focusing on tissue reconstruction, but the other important point is that people should know, women should know that you can get a very nice reconstruction with an implant too. We're just talking about
Sure.
the implant alternatives, right? So sometimes when we talk exclusively about tissue options, people get upset because they think that we're inferring that you shouldn't have an implant reconstruction, and that's not what we're saying. We're just saying there are other options too.
No, I think you're right. I mean, certainly when I talk to my patients about reconstruction and reconstructive options, I go through the whole gamut of what's available, which are essentially either implant-based reconstruction or autologous-based reconstruction using your own body tissue. And there are, of course, pros and cons to and merits to both types of reconstruction options. And, ultimately, it's a decision that as physicians, we have to, in a way, guide them, but also put it towards them as to what the options are. Because at the end of the day, whatever reconstruction somebody chooses, it has to be, first of all, suitable for the patient, but also it's something that they can have, because, of course, not everybody can have things that they may want to have, such as an implant-based reconstruction or an autologous-based reconstruction. And I guess that brings me to the question, which is, how do you decide whether a patient may be suitable for a DIEP reconstruction? Because, say, for example, they've decided against having an implant reconstruction for whatever reason, and they want to consider having specifically a DIEP reconstruction. How can you determine whether somebody's suitable for that?
Well, if they have the tissue in the right place, then you explore it as an option. So generally, I mean, I don't decide, we decide, because for some people, even if they're a really good DIEP flap candidate, it doesn't align with what they're looking for, their goals, their preferences, what's important to them. But generally speaking, just from a surgical decision standpoint, if someone's a candidate, if you've got the tissue, usually you're a candidate. If even if you've had previous abdominal surgery, which is actually, it's pretty uncommon now to come across a lady who has a breast cancer diagnosis or who's at high risk of developing breast cancer because of a gene mutation, or very, very strong family history, and they're looking at risk reduction, for example. But our population, it's very unusual to come across someone who's never had an abdominal surgery. So many women have had even if it's a C-section, for example, just one C-section, we get people from all over the place coming to us across the US and actually even other countries. And one of the things that I hear a lot is that they were previously told that because they've had previous abdominal surgery, they're not a candidate for DIEP flap reconstruction, which as a blanket statement is untrue. Now, if you've had a major abdominal surgery with hernia repairs and mesh and, multiple surgeries, sure, that's going to be, you may well not be a candidate, right? You might not be a candidate, but previous surgery doesn't automatically preclude DIEP flap reconstruction. And there are also scans that we can do ahead of time, special CT scans, CT angiograms that look at the blood vessels and to see if they've been cut by previous surgery. So from a surgical decision-making standpoint, if the patient wants to use their own tissue, they want to use their lower abdominal tissue, and they have tissue there. Mm-hmm. I mean, in our practice, it's really, really likely that you're a candidate, right? So, right. And the other thing is, DIEP flap surgery is associated. Another myth is that you have to be overweight to be a DIEP flap candidate, and that's not true either. So body mass index isn't a perfect tool to use to guide whether someone's a candidate or not, but
Right.
it's something that people are familiar with. So, a normal weight is a BMI of under 25-ish, 24, 25. We do deep flaps on people with BMIs as low as 19, 18, 19.
Wow.
That's so, and that's because the small amount of fat that lady may have, it's in the right place. They're having a one-sided reconstruction. They're having a one mastectomy. They're not reconstructing both breasts, and then now we can use all their lower belly tissue, and they have enough to match their current cup size, which they may be a B cup or something on the smaller, kind of more athletic build, for example, and now they're a candidate, right? So it's all about
Yeah.
matching the tissue someone has, how they carry it, and what's required in terms of amount of tissue to reconstruct their breast.
Right. So, I mean, essentially what you're saying is if somebody has enough tummy, enough fat around the tummy in the right place, then they, and also despite the fact that they may have had abdominal surgery, because as you said, you would do CT scans to make sure that the blood supply to the area that you're going to harvest is enough or adequate, then they shouldn't, they should by and large be a candidate for reconstruction. I guess the flip side would be if somebody came to you with good, tummy, which would be suitable, but there are other circumstances that might preclude them from having it. What would they be? So, what kind of factors would you consider that will make somebody not suitable for a DIEP?
Yeah, so what we just talked about, that's kind of limiting the conversation to the surgical side of things. There's also the medical side of things and other health conditions that can make someone kind of a lesser candidate. As with any surgery, the patient has to be completely tuned up from a medical standpoint. Like, if they're a diabetic, just if you have diabetes, that doesn't mean you can't have your surgery, you can't have reconstruction, but it does mean that your diabetes has to be under the best control that it can be to decrease the risk of wound healing problems and other issues. So you've got to get tuned up. If your blood pressure is high, that can increase your risk of complications. That's got to be controlled. The other thing we come across is connective tissue disorders, folks who have rheumatoid arthritis, lupus. There's a whole kind of bucket of autoimmune issues that can increase the risk of wound healing problems. So you've got to be careful there. Some people on medications that increase risk. Another big thing with us, with microsurgery, there are different ways to move tissue around. And if it's from the back, then the tissue, actually, the blood supply still remains intact. It's still connected. And the tissue is tunneled through the armpit into the chest. But
So that's if
other
it's an
option,
LD reconstruction, for example.
exactly, that's the latissimus flap. So the latissimus flap doesn't need microsurgery, but all the other options that are moved from further away on the body that have to be disconnected, transplanted, and reconnected, those are all involve microsurgery. And so the other issues that patients may bring to the table that increases risk are clotting problems. So there are some people that are predisposed to blood clots. So if you're someone who's had a blood clot in their leg, and there wasn't an obvious cause in particular, or if you've got a family history of blood clots, these things have to be considered and worked up, and you've got to really do your homework and make sure that there isn't something else going on. Because if you're predisposed to blood clots, then that increases the risk of the tissue not surviving after you transplant it, right? So these are all very, very successful procedures. So we have a 99% plus success rate in our practice, just like any other center of excellence that focuses on these tissues, on these tissue transplant procedures. So, you know how it is. The more focused a team is on a specific procedure, typically speaking, the better outcomes there are, right?
Yeah.
So
Yeah.
if you look at all the high volume centers that are focusing on these procedures, they all have extremely high success rates.
Yeah. No, I think you're absolutely right. I think that I guess this is something that people need to be aware of, is that if you are considering having these kind of surgeries, which are quite high risk surgeries, then you probably should consider going to a place where there is high volume, because the more you do, the more expert you become, and just the whole setup is there, the aftercare is there, which is as important as the surgery itself. So it's definitely something that people need to be aware of. The other thing that I would like to ask is smoking. So if somebody smokes, is that something that may stop you from going ahead with a DIEP surgery or DIEP surgery?
Yes, in our practice for sure. I don't operate on smokers, so it doesn't mean they're not going to get their surgery. It just means that they're not going to get their surgery while they're still smoking. So I know a cancer diagnosis is very stressful, and sometimes the crutch is smoking.
Yeah.
I'm not going to blame the patient for being a smoker, but they're entrusting me to help them get through this horrible time in their life and to come out the other end. And the focus has to be on minimizing risk and
Yes.
improving the chance of the best outcome that's possible. And continued smoking is not aligned with that goal. And for someone who's interested in reconstruction, but they won't stop smoking, then unfortunately they have to be accountable for the consequences of that decision. And that just means
Yes.
that unfortunately they're going to be in a position where they can't get reconstruction at the same time as the mastectomy, which is called immediate reconstruction. Immediate reconstruction is a bigger surgery than splitting the mastectomy and the reconstruction into separate procedures. But a smoker is at increased risk of lots of issues, including issues with healing after the mastectomy alone, in terms of the blood flow to the tissues that are left behind from the mastectomy. And then healing of the donor site, where the flap tissue to reconstruct the breast came from, whether that's a DIEP flap or anything else. So that patient will come back for a delayed reconstruction, which will be, at any time in the future, once they've been off their smokes and nicotine products for a few months, because that's the safest thing, right? So they need to be off their smokes for at least 6 weeks for me, and we vary in terms of plastic surgeon preferences. Some of my colleagues will do 4 weeks, others will do 8. For me, if it's a delayed reconstruction, I actually push it beyond, and I tell them 3 months, because why not, right? I mean, because your risk at 6 weeks is always going to still be more than your risk at 3 months,
Sure.
in terms of after you quit. And to have an immediate reconstruction, so at the same time as your mastectomy, you got to be off your cigarettes for at least 6 weeks.
Right. Okay.
To make that
I
palatable
think
risk profile, right?
Yeah, you're absolutely right. Those for patients who smoke, when you get a cancer diagnosis, as you said, it's the last, it's the worst time to ask somebody to stop smoking, because that's when you're most stressful, and you're probably going to increase the amount that you smoke. And so, smoking is a really difficult thing to tackle, because on one hand, you can understand why it might be difficult to quit, because, otherwise they probably would have quit a while ago.
Yeah.
But at the same time, you have to weigh up the balance and the risks between continuing to smoke and taking on that patient versus all the potential risks and complications. And I don't think it's, it is something that has to be explicitly discussed with the patient. But it is a really difficult thing because, it's, you just really feel for the patient, when they really want to try to stop smoking, but you can't because you're so stressed. And then as a result, you can't have the reconstruction. It must be really tough.
Yeah, no, it is for sure. And a lot of them feel they're being punished because they're not getting their reconstruction at the same time. And now they're going to have a lesser cosmetic result and more scarring. But honestly, going ahead with it because you want to give this patient the best cosmetic result actually really does them a disservice, because the cosmetic result isn't very good if you have a bunch of healing problems, wound healing problems, open wounds, and all this kind of stuff. It's the worst situation possible. But most people understand, that it's in their best interests.
Yeah, and also, the last thing you want is to potentially delay any other treatment that they may need, such as
that's such a great point.
Chemotherapy.
That's such a great point. So studies show that in general, reconstructing at the same time as a mastectomy, so an immediate reconstruction, does not delay chemotherapy for those folks who need it. However, to your point, if you take someone who's a bad candidate for reconstruction because they're smoking or because they have a bunch of other poorly controlled medical issues, and now you've greatly increased the risk of complications, that will absolutely increase the risk of delaying the chemotherapy. So it's definitely a team approach, and that's the other benefit of going to a center that does these sorts of procedures, is that those centers have a team approach. So all the specialists are involved in decision making. They have tumor boards, they have multidisciplinary teams and meetings. That's really what you want. You've got to pick your team. You shouldn't just pick your plastic surgeon. You've got to pick the team. Now, if you've had mastectomies or a mastectomy already, and this is the last step, then fine, you can just worry about the plastic surgeon usually. But if you're having an immediate reconstruction, you need the team.
Yeah, no, absolutely. And I think the team, as I mentioned before, the care for the patient takes into account the entirety of the journey and the process. So it's not just about, making the right decision and be fully informed about that decision. Any decision making has to be a mutual decision. Then you have the surgery, but then after that, it's the aftercare. Not only, the immediate post-operative aftercare with the anaesthetist that's involved, but also the team on the ward and the point of contact that they will have, moving forward. So following from that, then what is the recovery like if somebody, were to have this kind of reconstruction? What's the general kind of timeline, if you like?
Yeah, so that's a great question. So we tell our patients 4 to 6 weeks for the DIEP flap. And recovery, it means different things to different people. So by recovery, I mean you're back at work, and unless you have a really physical job. So if you've got a desk job, you're back at work. That's what recovery is. You're driving, you're going about your business, daily activities, may still be a little bit slower, but you're essentially back. So that's 4 to 6 weeks, depending on the person.
Right.
Again, things vary tremendously from institution to institution and between surgical teams. So even here in the US, our patients are going home after DIEP flap surgery now. Some of them are going home the next day, which 20 years ago was unheard of.
Yeah, that's really fast.
When I started practice, you were looking at 5 days in the hospital, and someone who left, after 4 days, that was like, oh, this patient left quickly. During my training, it was routine for patients. Every patient went to the ICU or intensive care unit, right? So things have changed tremendously, and the protocols are different. And so that's something else patients need to look out for. So we have an ARAS protocol.
Right.
That stands for Enhanced Recovery After Surgery, and that's made a world of difference. We started using that a few years ago, and that's what really brought down the length of stay. Our patients never go to the ICU unless they have a specific problem, so that's never been part of the standard post-operative recovery in our practice. But now we tell our patients, you're going to go home, either the next day, and if it's not the next day, late in the day, it'll be the day after. So overnight, or maybe 2 nights,
do they go home with the drains?
Yes. So
right.
Our practice, we send people home with drains, and then we see them in the office afterwards to get them out.
Right.
I do know some places that are really quick at taking out drains, but that's not us. I know I've come across some institutions where they take the drains out before the patient goes home, but I don't think the patient goes home as quickly as they do in our practice. So,
right.
And the nice thing about these protocols is that they're not. It really is a holistic protocol. It starts with appropriate education before the surgery. Setting expectations is crucial. They have a carbohydrate drink that they take. They drink the night before and the morning of.
Right.
So this, nothing to eat after midnight. We don't even do that. We want them to drink this clear drink. Now we're very specific in terms of what they can and cannot drink. It has to. The only thing they're allowed to drink is this drink that we give them.
The special drink.
And a special drink. Yeah. And it's carbohydrate. It's a clear carbohydrate drink. It's got some other stuff in it too, but it really helps with intestinal motility, and it decreases the impact of the general anesthetic on the intestines. Right. And so people start to eat a lot quicker after surgery. They don't get as bloated, and they don't have the issues that used to slow recovery down. Our patients also take pain pills before the surgery. So they go into surgery already with some pain medicine in their system. And then we do a bunch of stuff during surgery, like local anesthetic injections at the surgical site, or blocks, as we call them.
Right.
And then we have a very, very specific cocktail of medications. And they're non-narcotics. So they're not opiates. So at least for that standard cocktail that they take for 10 to 14 days.
Right.
The patients still have access to narcotics for breakthrough pain if they need them, but most of our patients, by the time they go home, a couple of days later, they're not depending on the narcotics at all, and they only take them at night, maybe for a few days. And so that, in conjunction with really pushing mobility, getting them up out of bed, the removal of the Foley catheter very early on, regular diet. I mean, people are recovering way, way quicker. It's still a big surgery, like you said before. So patients need to prepare appropriately. They need to have their support structure in place. This isn't something that you want to have done and go home to an empty house with no one to help you. So you've got to have your support structure. That's hard for some people. Some people, unfortunately, it's a struggle to get someone to come in and help. They don't have family, they don't have a spouse. But all that kind of stuff you've got to really focus on ahead of time. And then, so getting back to the patient and recovery specifically, you've got to be cognizant of what it is that's important to them that they need to get back to, right? So for some people, it's gardening. For other people, it's CrossFit. For other people, it's training for a marathon, right? I mean, we get people from all over with, different walks of life.
Yeah.
in our practice, we'll have, I'll see a farmer, and then the next patient will be a triathlete. They're very different situations, both very physical, but they need to get back to different things, and they each have different things that are important to them. So you've got to really focus on what the patient brings to the table, and really hear them out and encourage them to share,
Right.
What's going on in their lives, their situation, what they want, their preferences.
Yeah.
I think that's really key.
Yeah. No, I think that's really, really important. You're right. These are things that I think people perhaps don't necessarily think about, because you understandably just want to get the surgery done, get the reconstruction done, but then you have aftercare that needs to be met. And if you don't have that support structure, then these kind of surgeries may not always be able to be done because of that. So it's definitely something that we need to consider.
Yeah, or they're done, and people, your team didn't appreciate certain things, and they actually put you in a situation where you have to do more now, early on in your recovery than you should be doing, and that increases your risk of having a problem.
Yeah.
So
No,
communication is key.
yeah.
It's really important. And the other thing about reconstruction is that many people don't realize is that it can be done in one go, but I would say most people end up having more than one procedure to get
Right.
to the final result and to get the best result possible. So, I see, plastic surgeons advertising, one and done and this kind of thing. And sometimes you can get a really nice reconstruction in one go at the same time as a mastectomy, single stage, especially some implant reconstructions. You go direct to the implant, and the patient, skips the expanders and all that kind of stuff. And that's nice when you can do that if someone's a good candidate. But the vast majority of women who have breast reconstruction, it's more than one procedure, and it's a process. It takes
Yeah.
time. It's not one shot deal.
Yeah. And I think you need to set that expectation, don't you? Because as you said, most times you'll need to tweak this, tweak that, make it, do whatever you need to do to get the best symmetry as possible, to the liking of the patient. As you said, the majority of these kind of reconstructions actually succeed. In the big centers, the failure rate is anything between only 1% to 3%, very low. So the majority actually, work. But like any operation, there are always risks, right? So what are the main risks pertaining to this kind of surgery?
To DIEP flap specifically?
Yeah.
So you've got two kind of buckets of risk. So you've got surgical risk, which is the same for any surgical procedure. So bleeding, infection, wound healing problems. And that applies to both the belly and the chest. And you've got the risk of flap failure, which we've talked about. So the top centers boast failure rates of under 1%. If you look at the literature, 1% to 3% is kind of acceptable for a high volume center. And then you've got risk, post-operative risk, which again is any big surgery, things like blood clots, which is why it's important to get the patient up and moving. You don't want them to get a blood clot in the legs because they're not mobile and they're stuck in bed for too long. So you've got to get patients up and moving. And we have other prophylactic risk reducing measures like blood thinners that we give them, and special compression socks and squeezy mechanical things that we put on them.
Yeah. The boots.
The boots, yeah, exactly. And once they get out of the hospital, that risk goes down because they're moving more. And then longer term risk, specifically for the DIEP flap, it's if everything's successful, reconstruction is successful, then the risk is for the donor side. So the belly, you can have a bulge or a pooch because of laxity of the internal structures. You can even develop a hernia, which is the internal incisions that we make. So once you get through the skin and you dissect down through the tissues, there's a layer called the fascia, which is on top of the muscle. And the blood vessels that feed the lower belly tissue, we need to get those blood vessels out along with the tissue so that we can reconnect those blood vessels in the chest. But to get to those blood vessels, you've got to make an incision in this fascia, in this strength layer, and then you go into the muscle and you tease the blood vessels out. So then we repair the fascia, but if that fascia is weak, then it can bulge. If that repair breaks down, you can actually develop a hole in the repair, and then you get a proper hernia, a true hernia. And that requires more surgery to fix. And some bulges require more surgery to reinforce and fix. Thankfully, the risk of a bulge is less than 3%, and the risk of a hernia is less than 1%, again, in high volume centers. The risk goes up in women who have had multiple previous belly surgeries. So if you've had a couple of C-sections, an abdominal hysterectomy, and an umbilical hernia repair, you're going to be at much higher risk of a bulge or even a hernia than someone who's never had abdominal surgery, for example.
Yeah, because I guess your abdominal wall is weakened, isn't it?
It's weakened, and so we don't use many meshes or kind of reinforcement materials. It's not routinely part of the procedure, but we will use those to reinforce things in those ladies who are high risk. And doing it in that kind of selected population has definitely cut down the numbers of issues. Right. Other long-term issues, again, after any surgery, can be chronic pain. There's a syndrome called post-mastectomy syndrome, which is obviously not related to the reconstruction at all, but that's chronic nerve pain that happens after a mastectomy. It's a bit of a misnomer because you can get it after a lumpectomy as well.
That's true.
And then chronic muscle weakness is also a risk of the DIEP Flap procedure. Again, super important to seek out specialists that do this day in, day out, because they are more likely to preserve the nerves in your abdomen that power your muscles so that you can maintain your long-term strength. Because that's another risk of if you cut. So the reason the DIEP Flap is the gold standard now is because it preserves all your muscles. But if the analogy I use is with patients, and they seem to understand this, is someone who's been paralyzed. So if someone's in a wheelchair because they've been paralyzed, let's say they broke their spine, car wreck or something, right? Well, after a while, those patients lose all the muscle mass in their legs. So they're literally, it looks like they're just skin and bone, right? They've got very little muscle mass. Well, they haven't had those muscles removed. It's just the muscles aren't powered anymore, and then they waste away, they atrophy. So it's the same thing with your belly. If you go in and you do a DIEP Flap and you save all the muscle, well, you've still got to make sure you save the nerves that power the muscles. Otherwise, they're going to waste away, atrophy, and you end up in a position where you're not much better off than if the muscles had been cut out with an old-fashioned TRAM flap, right? So it's really, again, we keep coming back to the importance of doing your homework and making sure that you can hopefully see someone who does this a lot. And in the US, I think patients are kind of in tune with that, and pretty open to, getting a second opinion, doing their own homework.
Yeah.
I think I get when I was coming through the system in the UK, the culture was different, and I think it still is different. I think people aren't so quick to ask questions, and I think they're very quick to presume that they're in the right hands, and they don't ask the right questions sometimes.
Yeah.
So
No, I
these
think,
podcasts are super important to get people, to encourage people to start thinking about it, right? And chances
yeah.
are, if you've been sent to the surgeon, they probably are the best person for you. But sometimes they may not be.
Yeah, just get a little bit more information about it. The other thing
Yeah.
that we do see would be things like, fat necrosis and oil cysts in the reconstructed breast. Can you
Yeah.
talk
So
about that a little?
fat necrosis, fat necrosis definitely is a risk. It's about a 10% rate, 10 to 14% rate, based on the literature. What that means is that a part of the tissue that was transplanted, so a part of the flap, which is essentially all fat, that an area of fat didn't have very good blood flow, very good blood supply, and so it basically turned hard and turned into a scar, or this ball of hard scar. And so that's fat necrosis. It's not harmful, doesn't turn into cancer. There are some women that have never had breast surgery, and they have kind of lumpy, bumpy breasts. So if you have small areas of fat necrosis, that's what it can feel like. Sometimes the area of fat necrosis can be large, and it can even be tender and painful, and it can even be visible if it forms this ball.
Right.
And so in those situations, we have to do something about it. Sometimes we can remove it all. Sometimes removing it all causes too much of a defect, and so we have to just kind of break it up or shave it down. Or there's a variety of things that we do to either remove it or camouflage it. That's definitely something to bear in mind with any tissue reconstruction. Oil cysts, we don't see those at the initial reconstruction. We see oil cysts sometimes after we inject fat. So that's called fat grafting or lipofilling, it's still transferring fat, but that's not transferring it as one big piece like a flap does. Fat grafting transfers fat by sucking it out using liposuction, purifying the fat, and then re-injecting it. So when you do that, though, you do sometimes get some of the fatty oils. And if you don't look out for what you're injecting, if you don't really look at it, and we're very careful, and we actually drain all the oils out so that we don't inject that back in. But sometimes some oil droplets do get in, and you can get these oil cysts that need to be drained and can cause some anxiety as well.
Yeah.
Fat grafting, liposuction and injecting fat. So fat grafting is usually used as an adjunct, so in conjunction with another form of reconstruction to kind of add the finishing touches. So fat grafting is very, very frequently used with implant reconstruction too, to camouflage the implant some more. And we use it a lot with our tissue reconstructions to fill in contour defects after the mastectomy, maybe add some more volume. I use it very frequently to kind of what I call feather the reconstruction. So what I mean by that is injecting fat at the top, basically between the top part of the chest and the flap that we've moved up, to just provide a nice smooth transition between the two. So it looks like a natural, far more natural breast. So you don't get that step off.
Yeah. So more like a slope than it becomes, doesn't it?
Exactly, yeah. So especially when women wear a bra, and push up the reconstructed breasts, sometimes you can get a bit of a ledgy appearance up top if you don't kind of think of things along those terms, and sometimes fat grafting can be really helpful to do that. And that's typically done at the second surgery. So again, Earlier, we briefly touched on the fact that this is usually a staged approach for most women. So in our practice, for example, the first surgery is making the woman physically whole because she wants to be reconstructed. And there are certain things we do to set the stage for the best final cosmetic result. But the actual fine tuning and maximizing the cosmetic result happens at a subsequent surgery at stage 2, which is an outpatient procedure. So the patient just goes home the same day. And that's things like scar revision, working on breast symmetry. If they've had a one-sided mastectomy and reconstruction, maybe a lift or reduction or augmentation or whatever on the other natural breast. Fine-tuning the donor site. So in the case of the belly, it's scar revision, liposuctioning. And then we if we're doing liposuction to contour things, then that fat is used for fat grafting for, finishing touches of the breast too. So it's a whole menu of items that nipple reconstruction. If the lady wants a nipple and didn't have a nipple sparing. So for us, we do that at stage 2. Some institutions do that at the initial stage.
Yeah.
So there are lots of ways around the mountain, right? So it kind of depends on the place.
Yeah. I mean, it's just been a fascinating conversation here, because for everybody who's been listening, it's really, really obvious that it's not, it's quite a complex procedure. It's a complex decision to make. There's lots of things to think about for the patient and also for the surgeon who's going to be doing it, because as already mentioned, there are so many factors that come into play as to whether this type of surgery should go ahead. And so for you as the surgeon, how can you, do you have ways and means to help decision making for your patients?
Yes. So after you've been doing this for a while, I got to the point where, all my technical boxes had been checked, right? So I know how to do these procedures. And sure, you're fine tuning, you're always learning, always having conversations with colleagues, see where we can improve, always going to meetings, all that kind of stuff, right? But basically, you get to the point where, you're an expert in your field, like anything, right? You do it enough, you get good, right? Hopefully really good. And then other things come into play. And so for me, it was, once our practice got to the point where we were seeing a bunch of people from different places and they were traveling, I kept hearing the same thing. So things like, why didn't I know this before? Why did no one tell me this? Well, if I had known this then I would have done something completely different. Why didn't someone tell me that I was going to be numb after my mastectomy? What do you mean I could have had a nerve reconstruction to restore feeling in my breasts? All these things.
Yeah.
And so I thought, I surgically touch about 300 women a year. And there are thousands of new diagnoses every year, whether it's cancer or a gene mutation. There's got to be something out there that helps educate patients, that helps them arm themselves with the knowledge, do their own research before they come, really involve them in the decision-making process. And then lo and behold, that philosophy existed, which I didn't realize it existed until I really started looking into it. And that's called shared decision-making. So then I thought, well, there's got to be an app for that. So I tried looking for an app, and nope, nothing out there for breast surgery in particular.
Yeah. Not
really. So then we got a team together and we created the Breast Advocate app that, you know about. And so that's what we use now. So we use that. Everyone who's going to come in and see me gets a link to, well, it's on the App Store and Google Play, so you don't even need a link, but we tell them to download it. And then they go through the app, as many times as they want, comfort of their own home. And then, doctors don't have the time they used to anymore. We don't, we have in our practice, we're very, very lucky, and we can allocate a good amount of time for each patient, and we take pride in that, actually. But my initial consultation times now have been reduced from an hour to 45 minutes and then to half an hour, because quite frankly, people who download the app know enough to decide what they want to talk about. And
Sure.
so instead of having to repeat the same spiel about all the options and all the it and all the stuff, which takes 45 minutes, I don't even do that anymore unless the patient needs to hear it, because they come in and they say things like, well, actually, I've looked into stuff, and I don't want an implant because I don't want anything foreign in my body. Or I have other people come in and say, I've really considered the pros and cons of all this, but, and tissue sounds good, but I'm not ready for a big scar on another part of my body. I think I'm going to go with implants. They really focus in on what's important to them. So, yeah, the Breast Advocate app has been very, very useful in terms of unburdening the clinic in terms of time. And then it also allows you to spend, so now you're spending less time with a patient because you don't need to explain absolutely everything, and you just need to validate what they know, which takes less time. But now the time that you do have with them is super customized and personalized because they're educated enough and now they want to talk about the stuff that's specific to them. And so now you spend less time, more focused, and they're actually happier.
Yeah.
And they come out with a better plan, and they're more bought in, and they do better. So, because, we mentioned complications before, and all surgeons have complications. We all do. It's a nature. It's part of the, that's the nature of the beast. Surgeons who don't have complications are either delusional, are lying, or never operate. Right?
Yeah.
So
or haven't operated enough.
Or haven't operated. Yeah, right. So, but when you involve the patient to this degree, and you have a shared decision-making approach, that also helps you build the relationship. And then if they have an issue, they feel, and rightly so, that you and the team will get them through it together.
Yeah.
And so they're more compliant. They do everything you ask them to do. They're bought in. But even if after all that they have a problem, then you just focus on the problem. There isn't this, decision or regret, oh, why did I do this? Or why, could I have done something else? They've already gone through all that and unpacked it all, right?
Yeah.
So that's been super helpful for us.
Yeah, no, I think, and I'll leave it in the link in the show notes, but as I said, you can get it, the Breast Advocate app, you can get it on Apple Store and Google Play. But it's a fantastic thing that you've created because, as you said, it kind of, it empowers patients to make the decision from the outset. So by the time, they've already filtered what they want, what they don't want, what, may work for them, what won't work for them. In their own kind of, environment, in their own space, in their own time. So by the time they see you, they're already, laser focused because they already know what they want. They've already filtered out the stuff that they really don't want to hear because they already know about it all. And the quality of discussions that they have with you can only be, a quality discussion and a quality, well-informed, succinct clinic consultation, because they've already come to you armed with the knowledge that they know exactly what they want to talk about. And if they haven't got the answers, at home after they've gone through the app, then that's what they're going to see you for, to get the answers, to either validate, yes, they really want to proceed, or validate, no, actually, I've decided not to go ahead with it, whatever it is. But giving, I think that what you've given them is empowerment, really, to allow them to make a decision without the pressure of having to get all of this information during a clinic consultation, because it's too much, you know. I mean, there's so much information. Just listening, for those listening to this podcast, if you're listening to it from a place where you don't know anything about this kind of reconstruction, your mind is going to be completely blown away, because, you know, there's so much to talk about, and not only to listen to it, but then you have to digest it and, you know, kind of figure it all out in your own head. And it's way too much information. So definitely leave the the link in the show notes. So Dr. C, as most of your friends and colleagues call you, this has been a fascinating conversation. Thank you so much for joining me today. As a parting word, do you have anything left to tell or to impart onto those listening to this fantastic conversation?
My final piece of advice would be, I know this feels like an emergency, but you actually do have a little bit of time to get as comfortable as you need to with your options. Do your homework. It's hard for sure. It's a very trying time, especially with a cancer diagnosis. But you do have some time to work out what's best for you. And I would say find your voice, and express your voice. You as the patient are also an expert. You are an expert in your life and what's important to you, and that stuff matters, because it's going to impact how happy you are with your decision, because the only people that are left with the consequences of this decision long term are you and your family. So I would say, to hitchhike off your patient empowerment comment, I couldn't agree more. I would say take that to heart and find your voice.
Amazing. I love that. Thank you so much. And for those who want to connect with you and find out more about you, where would you like them to go?
Oh, man, I'm everywhere. Facebook, LinkedIn, Twitter. Probably those are the top three. But yeah, okay. So we, me personally, or Breast Advocate. Breast Advocate is on all the social media channels too. So ultimately the message will get to me one way or another.
So there you go. So Dr. C is omnipresent on the internet. So I'm sure but I'll leave his kind of links in the show notes as well. So for anybody who wants to connect with Dr. C, then you'll find him there. Thank you so much once again. Really, really appreciate you spending time with us, and I hope to catch up with you soon. Take care.
Lovely. Thank you. Bye.
Bye-bye.